Aloha, welcome to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island and ER physician. We've had a long-standing discussion here about healthcare in Hawaii for these past many months, and today I'm bringing back one of our favorite guests, Beth Giesting. Beth is the health czar for the Abercrombie administration and has been leading the charge on healthcare transformation. So I called Beth last week and I said, Beth, it's time for us to update our conversation, and she said, I have someone for you to meet. Bryan Fitzgerald, who is our project director and the statewide health technology advocate. He's working on a healthcare database, and today's program is entitled Hawaii's Health Technology Future. He's a lawyer. She's going to give us a little bit more details about Bryan, but I wanted to bring in some new ideas, new blood to our conversation, and talk really about where we're heading with healthcare transformation. So thanks for joining us. So next, I'd like to say welcome back, Beth. How are you?
I am great, and thank you very much for having me back.
It's great to have you. So I want to give you the opportunity. You know Bryan better than I. Why don't you tell us a little bit about why you brought Bryan into the program, into the fold, and then we're going to kind of turn it over to him and riff for an hour.
Okay. Well, you know, we have been developing all kinds of aspects for our healthcare transformation plan, and so we're talking about changing the way care is delivered, the way it's paid for, our health care workforce, the policy, but health information and health information technology is among the most important things that we're working on. And we found as we were developing our plan that the state itself is not data rich. It doesn't have a whole lot of good actionable information about what's going on in our communities, where there is a particular disease burden, or even why we are typically number one in the nation in terms of being the healthiest state in the country.
Right.
So we need to understand many aspects of what's going on in our healthcare system. And so we were fortunate to get a grant to develop a health information database.
Right.
And then I was fortunate enough to find Bryan, who, as you noted, is an attorney, previously was a deputy attorney general,
right,
and has background in working with an IT company and a number of other fine attributes that I'm going to let him talk mostly about. And I think that I would mostly want you and Bryan to be talking to each other this afternoon.
Okay. Well, thank you so much for bringing Bryan. Bryan, tell us a little bit about yourself.
Well, thanks a lot, Doctor. I got started in Hawaii doing health technology in a legal setting back in the days of David Shutter. If any of your viewers are old enough to remember back to the 80s, Mr. Shutter was really a thought leader in Hawaii. We had database systems to work on what was the Dalcon Shield case at the time, a really ugly piece of litigation. But by using technology, Mr. Shutter was able to get a lot more manpower out of fewer resources. And that's often the way it is with technology. You can pour more money and more people and more hours into it, but technology becomes a multiplying factor. By using the latest technology, he was able to get a big leg up on everybody else in the sector.
Right.
After that, I worked for a few other firms in town. One setting up the database for the asbestos litigation, which was another health-related huge problem. Hundreds and hundreds of defendants,
right,
and thousands of people that were hurt,
yes,
with asbestos. Big challenge, and at each iteration, the technology got bigger and stronger and more simple in a way. I remember Minolta used to have a slogan back in the 70s, so complicated it's simple. Remember we had those 35 millimeter cameras with so many knobs. Minolta was the one that finally figured out when you get to a certain level of technology, it becomes user friendly.
Right.
And that's where we are in Hawaii's health technology now. It's becoming so sophisticated that even lawyers and doctors can use it.
Yes, well,
Yeah.
I'll tell you, I have so many docs in my my organization, my IPA organization, that that many of them had a reluctance to adopt, and that was it's both understandable and frustrating, because I know that it's going to take that certain there's a breadth of time that's going to have to pass that they're engaged to make it work, and if we don't get them started through people like you guys with that kind of gentle nudge, it just won't happen, and they won't get to a place where they're comfortable. I'm 44 years old, and in my generation, it was very easy for me to adopt technology because I I grew up with a computer. I started in high school with computers, and it was very easy to imagine having an iPad or whatever device. As you saw when we were coming in together, just in the first couple seconds, I was finishing my medical charts from this weekend, distant, from a distant site. Whereas I have a lot of physicians that just don't want to do it still. What are you doing for those people? How are you bringing them into the fold?
Well, it's funny you should mention the age factor. I've got a bunch of kids, and even the difference between me and the kids, a lot of guys understand that. For instance, when they say, well, what is this symbol for saving? I go, well, that's a thing called the floppy disk. Or, for a telephone, they have no idea that a telephone was a thing you held up to your head and not a rectangle. It's no different with doctors and lawyers. They came out in different iterations as well. If you start with scribbles on a pad, and your physician's assistants and your nurses can read it, and the pharmacist can read it, well, that's good enough. Why should we change, says many of them. Right. But the problem is that doesn't scale up, right? When we're in a world where you want to be portable, you want to be able to be on vacation and have access to those records, we have that now. And in their private lives, doctors understand a lot of it. They use cell phones with apps and all these other things. Well, it's time that we use some of the big data, is a sort of a buzzword that maybe you've heard, applications, applying it to the data that we have now. And it's important to note that data in and of itself is meaningless. Data is when you go to the gas station and you gas up and you get the receipt, you put that in your glove compartment and it files up and it falls out every time you open it. That's data. It doesn't help you. But when you take all of that out and you sit on your kitchen table and you add it up and you realize, Thursdays is the best day to go. The least way. That's information, and that's actionable. In a healthcare setting, the same thing is true. We've got lots and lots of data in Hawaii, but no actionable information. And so what the grant that we got from the federal government does is allows us to stack that data by the analytics, or is this type of a software that allows us to slice through that data and get actionable information.
Right. Now tell me this. So you came into the scene, Beth and the team decided they needed an expert. They bring you in. What did you first see when you got here? I mean, you said we have a lot of data. Was it organized, disorganized? Were you surprised to see where we were as a state? What was your first impression?
Well, it's much like many environments. It was siloed. It was in a lot of different places in a lot of different formats. After I got done doing some of the local work, I went to the mainland and was doing what's called customer relationship management databasing, and that's when you use your supermarket loyal customers card, that information is gathered and stored, and it's siloed. And when you add that data to other data, that's where you get the actionable information. So in the banking, finance, retail world, it's really no different from the medical world, with the possible exception that lawyers and doctors are somewhat more resistant to change than other industries because of the obvious privacy concerns.
Because they're know-it-alls. I'm married to a lawyer, and I work with doctors, and I think I'll say it if you don't want to say it. Yes, they are resistant to change, but that's because they know how they think that it should be done. But this seems to be this is a new layer on the healthcare system, this technological information age, it seems to me. Because I'll tell you candidly, even in my training, which was not really that long ago, I was in medical school from 93 to 97, in residency 97 to 2000. Honestly, we really didn't utilize computers almost at all. I pulled up the labs. That was about the extent to which we were using computers. And now, every one of my visits are computer from beginning to end. And that's just in the course of, only a 14-year window where it's changed 100%. So it seems to me that you came into an era now in this healthcare system where it really does have to change. Now, Beth, when we spoke last time, you also mentioned one of the challenges was that we have silos and the departments weren't speaking together. Can you tell us a little bit about, will Bryan's work help to integrate these programs? Are you getting some more cooperation from the multiple different areas of healthcare to start working together? How's it looking?
Oh yes, I think that this next phase we will have a much better process to bring all of the state agencies that need to be working together on healthcare. And I think that Bryan's work is going to help us with that, because the state does have a whole lot of information in the Medicaid program, potentially in the Employer Union Trust Fund. The Department of Health has a great, vast store of information, and none of it, of course, is formatted and very accessible for us to use. But as we move forward, we know that there are all of these resources that we can pull together once we have a better idea about what their structure is, how to aggregate it, how to analyze it. But we're really looking forward to this, because the next phase of our planning, we expect to be looking more at behavioral health and improving that in Hawaii. And one of the things that we found is that not even the Department of Health has good information about population health here. So what is the percentage of people in our population in any given community that have needs that are or are not being addressed? And we just don't have that yet.
It seems so relevant that you mentioned that, because even in recent weeks when I had George Green come to talk to us at the Healthcare Association, as we all know, that their report was quite comprehensive, and it talked about how the largest share of preventable hospitalizations was in serious and advanced mental illness, right? Mm-hmm. And at the same time, we're seeing this pretty large explosion of activity around the Hawaii State Hospital, where we're having these discussions and we're trying to improve the facility and help the Department of Health to make that facility more accessible for our needs. But as we see right now, we have a very big challenge. We have a mismatch between the individuals that have to be, housed at the hospital and get really advanced care, and the many people in our midst. As much as 30% of the population at some time in their life has some treatable mental illness that needs to be addressed, and there's a disconnect I see that maybe you guys are going to be able to bridge. But it sounds to me like we can't even really, what you're saying is, get a full grasp of the problem without this technological and information approach.
Yeah, I think that we need to build the infrastructure, and that's what Bryan is here to do.
That's right, Doctor. There's three phases. The first one is descriptive. Once you have the data and are able to start analyzing, you can describe what the problem is. Right. And that's huge. We don't even have that. If I told you Hawaii's the healthiest state in the union, that's great. Why? Well, spam. We eat a lot of spam. It might be that. We don't know. Probably not, but if the spam people, before Miller's watching, you can send the great the doctor.
Please no.
After descriptive, then comes the predictive. We know what's happening. Once we have enough data, we can predict what's going to happen next. Right. And the third phase, and this is really down the road, is prescriptive. We know what's happened, we know what's likely to happen, and what are we going to do about it? That's the ultimate goal, the progression of data analysis that we're looking to do.
I think that is an excellent way for us to frame our first 15 minutes. Why don't we take a brief break, and then we're going to dive in and break out a little bit more what you mean by these different, the descriptive, the predictive, and then the prescriptive process. But again, thank you so much for joining me today. I'm Josh Green, Healthcare in Hawaii. Thanks for joining our show.
Hello, I'm Martin Despang, and I'm the host together with the one and only Ali Yamashita, and our show is called Urban Transcendence. And Urban Transcendence is about identifying we have a unique situation of a vibrant city in one of the most beautiful natural environments. So how these two can coincide, sometimes conflict, how they could find reciprocity in the 21st century is what we're excited about. And we're planning on bringing in a diverse body of guests, both from the arts and the science and the established and the wise and the emerging generation. So hope you will join us. We'll always be on Thursdays from 1 to 2 p.m. Thank you very much.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, Senator and Big Island ER Doc. I also work with the Hawaii IPA, which is an 800 physician member group that's struggling with one of these issues, which is how to get technology and health information into a place where we can really use it for the betterment of our patient care. So today I'm lucky enough to have Beth Giesting, and then joined with her, Bryan Fitzgerald, who's joined the team to really begin to solve some of these problems as the project director for what we're calling the Healthcare Technology Advocate position. It's a healthcare database position. Bryan's a lawyer. He's joined us and begun to tell us about breaking down the silos so that we can make all this healthcare information usable in a way that really will work, I guess, on the triple aim, which is one of those, it's a cliche almost that we've talked about, but to get people better care that's cost effective and really just kind of more accessible in general. You usually say what the triple aim plus one, right?
That's right.
What's your plus one?
So our plus one is about making sure that no group gets left behind. We want to deal with health disparities and make sure that everybody has an opportunity to be healthy.
And to get to health disparities, we have to know what the heck we've got, which is the descriptive piece that we were just talking about with Bryan just a moment ago. So Bryan, maybe why don't we start there? The state of Hawaii, you came on board not long ago with your background of expertise in health technology, but also information technology. When you see Hawaii and you see someone like Beth fighting for people that don't have access to care, that have these additional impediments to get quality access, how do you think you'll bring our tech system and our information system up to speed so you can help her with her goals?
Well, we were talking earlier about the three phases, first being descriptive, and that's right what we're talking about right now. And how do we describe the problem? There's a thing called the heat map, where you take this data and you can track it out and you can see, you know what, when you map obesity and you map diabetes, it's almost a perfect circle, one atop the other, and you can start to see things like that. Now, in the public health sphere, this is not theoretical. This is not rocket science. This is something that we've done right now.
Right.
In the accident world, they mapped the GPS positions of where accidents were with the injury, with the treatment data, and guess what? We can tell you now where you don't want to cross at 2 o'clock in the morning.
Right.
That's the kind of information that is descriptive. Now, does that tell you where the next one's going to be? Not yet, but that's where we're going. So that's the first mission, is to find out exactly where our health problems are and the cost and quality.
Let me ask you a question, because this has come up and I found this to be an interesting statement. Just get your opinion about it. We had a presentation, I guess, from the banking community actually, and they said to us that zip code is now more predictive for your health outcomes than genetic code. And I thought it was clever at the time, and I kind of understood what they were saying. For instance, zip code, if you're living in Ka'u, where I did my National Health Corps assignment, or Waianae, that zip code might indicate that you're going to have a higher incidence because of poverty and other conditions in the community of diabetes, hypertension, and so on. Same thing for other rural areas in our state. Are you finding that? Is that a meaningful statement when you, someone who has experience in health information, hears that?
Absolutely. The thing that's interesting, though, we don't need expensive computers to tell us that if you're smoking and obese, you're going to have a problem.
Right.
Or if you're from a neighborhood that doesn't have proper health care or nutrition, you're going to have a problem. The thing that, the huge value add that big data brings to this is the non-intuitive connections. In the retail market, they often refer to it as the beer and diapers phenomenon.
Tell us what's that.
The beer and diapers phenomenon, to the amazement of those, they call them POS or point, I try not to use the TLAs or three-letter acronyms,
Yes.
but the point of sale data, they found that for some reason right before the weekends, there was a huge correlation between diaper purchases and beer purchases. Well, they couldn't figure it out, so they looked into it, and lo and behold, it comes to find out it's the younger dads that are being dispatched to go get the diapers, and they're saying, well, if that's it, I'm going to grab some beer. Well, that's data,
Yes.
right? And you got the descriptive data based on the analytics.
Right.
Well, what is the action plan? Let's move the beer display closer to the diaper display, and also raise the price of beer on the weekends.
Right.
Guess what? Now you've got a result. In the health world, exactly the same thing is going to occur. Now, can I tell you exactly where, when, and how? Again, I don't think we need necessarily a lot of data to tell us smoking is bad and obesity is bad, and if you've got a family history, that these are all risk factors. We know that. It's the overlapping of the data from these various sources being brought together that is going to bring us the real actionable information and a plan for not just another database, but really information that doctors and policy leaders can act on.
No, I appreciate that, because from wearing my Senate hat, a lot of times I have, well, let me give you a couple examples. I get a call from someone in the community, very savvy person, and they've noticed that they describe to me that a series of friends of theirs have had cancer, for instance. They wonder to me aloud why this wasn't the case 20 years ago. So the easy part for me to say is, well, you know, your friends are now in their 60s and 70s, and before they were in their 40s and 50s, and there is definitely an increase in risk, right, as you're older. But then this person goes on to say to me, yes, but this very specific malignancy, we've had 3 of this particular malignancy in this block. Is that an issue? And then I don't have an answer. So I would love it if I'm able to, right now my current approach is I call the director of health, who's a friend, and I say, do you have any data? Do you have anything? And they usually work hard to find out whether there have been extra reports from the local docs or the nurse practitioners. Have there been extra, epidemiologic reports? But a lot of times it's very challenging for them. I was speaking to a gentleman who's in pharma the other day, very nice guy, and he had a brain tumor. He told me, and he's in the Seattle area. He said, and I empathized with him, and it was, he's doing great. But then he told me also that his daughter died of a brain tumor at age 20, and which was tragic. Then he went on to tell me that his 10-week-old had died of a very rare malignancy, and they were all living and working many years before in an area where there were nuclear reactors. He wanted to know whether or not someone could give him some information, very well-educated guy working in the pharmaceutical industry, whether someone could tell him whether or not there was a risk. The reason they couldn't tell him at this time was because the way they aggregated the data was based on where you got your treatment. And in his particular case, they went to 3 different treatment areas, just so happened, 3 different centers, and they were registered there. Now, with a person like you coming aboard, what do you foresee in the future? Will we be able to get a quick answer on, yes, this is a potential risk or cluster? And that doesn't have to be cancer, it could be diabetes or heart disease or whatever. How will that work?
Well, what you're talking about here is a data access issue.
Yes.
And guess what? It's more than just consumers that are very, very interested to look at what the most genetically diverse population group in the planet, that's Hawaii,
yes,
in the most isolated landmass, that's Hawaii,
yes,
is the healthiest group in the planet. That's a value. And obviously, we want to know more about health hotspots. Maybe I don't want to be near this particular factory. Fortunately, we don't have a lot. Maybe that has something to do with the fact that we're the healthiest. We don't have a lot of heavy smokestacks. But in addition to that, insurance companies who are in the business of good health,
yes,
right? You are the best customer for an insurance company if you can live to 120 years old, never get sick, and fall down getting dancing lessons at the age of 120.
Yes.
That you're their dream customer. They're in the health business. They want to know this information. Drug companies, medical device manufacturing companies, insurance companies are not the only ones. There's a lot of people, not to mention the federal government, who now is in the position of a big insurance company themselves.
Yeah.
They want this data as much as we do as parents and children of people in the healthcare system.
Yeah, well, that's why I've been, to this point engaged and, kind of a willing partner. Because I will tell you this, and I shared this with you very candidly right before we started our show. As a clinician, it's a little slow right now. I mean, people are getting up to speed with the systems, and they can be clunky. And when I worked in Africa for 6 months, I'll tell you, this was it. This was my chart for a patient, right? Honest to goodness. And that patient would come back 3 or 4 times in 6 months. You just wrote down one more line on the chart, gave them what medicine you could, and off they went until they were either in more need of care or totally better. And the technology, it didn't exist, but I could see 80, 100 patients in a day. And it was just me, the same provider, same physician, taking care of them. Now, if I were to try to see those 80 patients in a day, it would be a 48-hour day around the clock by the time I documented everything, loaded this program, embedded it with data, and so on. However, I really am keen on, in that setting, I would have had no idea whether I could tell that nice group of people in a very rural community, yes, you have this health population problem, or you don't. Whereas now with this data, if I have the good minds from you and Beth, I have hope that when someone makes that call to me in the future and says, Senator Green, do we have a higher risk of cancer because we're near Pohakuloa? Do we have a higher risk of heart disease because of extra sodium in the water, which has been a problem locally in some of the neighbor island communities? And if we can say scientifically, no, we don't have a higher problem, let's move on and devote our resources in another way, I think it's going to be very good for us. But I do think we're going through a growing pains era right now, and we're going to rely on you to make it less painful, I think.
You're absolutely right. If you can tell me, you know what, your house is in a perfectly good location, that's that much less stress. And as we know, stress is a big multiplying effect for all the health issues. So as to your base point, the technology right now, the user interface for doctors, insurance companies, patients, is not all the way there. It's pretty obvious.
Yes.
But when you consider the growth curve, back in the 90s when some of these things were first being implemented, it was a green screen with a little cursor. There were no pictures, there were no movies, there were no apps.
Yes.
Right? So between then and now, it's light years of difference. When you consider that medical record that you had, that little card, some doctors have the brightly colored ones with the color codes so the physician's assistant can pull it in, but maybe a kilobyte of data, more or less. You could fit 5 patients on one floppy disk.
Right.
The kids now know what floppy disks are. I had to go get one. It was out in the garage. I showed them what one was. But from there, here we are today. How much information would you have in any particular patient's files? I mean, you've got MRIs, you've got all manner. I mean, we're talking about gigabytes of information. And you don't have to be Nostradamus to see where this is going. It's ramping up very, very quickly.
Yes.
Soon there'll be all manner of testing information, ultimately genomic information. It'll be there. It's not warp drive science fiction going into the future. This is where the future's going. It's getting cheaper and cheaper. So we've got to build our system to have the capacity to grow into that, and then we're really talking about a future it's going to be hard to imagine.
Yeah, it's very exciting. I think we've spoken about some of the kind of the macro economic questions of healthcare on our program before, and I think when people realize that health is a $3 trillion industry in the country, diabetes, a $300 billion industry alone, basically approaching the cost of our Defense Department, they start to see that if we don't do it well, if we don't decrease some of the waste and some of the mistakes that we make, we're really losing a great opportunity. I personally believe, I don't know if healthcare will ever get less expensive, but I do believe that, at least in our country, 20% of it can be improved, we can deliver it better if we put good systems into place, which I'm fairly convinced is going to be based on health information. And that is an opportunity for us in our country. So I think it's very good that you're here. Why don't we take our second break, and when we come back, we'll talk about the specifics of your program for the state of Hawaii. Sound okay?
Great.
Okay. Again, this is Josh Green. I'm your host with Healthcare in Hawaii. Thanks for joining us.
I'm Hong Jiang, host for Asia in Review on Tuesdays.
And I'm David Day, host for Asian Review on Thursdays. Both of us broadcast our respective shows at 4 p.m.
And my topics tend to deal with questions related to environment, culture, history, and sometimes human rights.
And my shows tend to be on international business, foreign policy, geopolitics, and national security. And you can watch our shows live on the ThinkTech website at thinktechhawaii.com.
And you can also watch us on YouTube or Olalo.
So come join us on Thursdays at 4 p.m. I'm David Day.
And on Tuesdays at 4 p.m., I'm Hong Jiang.
Aloha.
Aloha.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island and a physician practicing in our ERs across the state. Today we're talking about healthcare information, and we're joined by Bryan Fitzgerald and Beth Giesting, both with the administration here in our state, the Abercrombie administration, and they're working specifically to make sure that healthcare becomes modernized, that we work on systems approaches that make our healthcare system more efficient, that we use data in an intelligent way, that we make it descriptive, predictive, and ultimately prescriptive, so that our system can actually work for the benefit of patients and get resources where they need to be. We've talked a little bit about what you're doing, Bryan, but I think I'd like to get some information about, Beth and I talked about this, what's called the All-Payer Claims Database. I just really want to learn what the basics of that are, what you're doing, how is it safe, sharing this information, how's it going to work?
Sure. It's one of the acronyms, the APCD, or All-Payer Claims Database. It's a program that's been around since the 90s. Basically gathers information from the various payers of health care services, being insurance companies and the government.
Right.
By aggregating that data separate from the personal information, certain information can be drawn from that. About 15 other states have this to greater or lesser degrees of implementation. So that's going to be the foundation upon which we build. It's already been done. We can look at the successful implementations in other states. A lot of challenges in working with this data because it's people's health records,
right.
And there's a lot of legal and ethical problems with going there for obvious reasons. So the state has been working on this, the federal government has been working on this, so it's a balancing act. We want the information, but we want to do it in a way that is secure and impervious to attack, and that's something we spend a lot of time working on.
Well, I remember in the early days of my practice, the big issue was people's HIV status, for instance. It's very private, it's very personal, and it's of course somewhat tragic when someone comes up positive. Though now we're doing infinitely better taking care of people, making it into a chronic disease, but. The impact of it getting out into the community, especially a small community, people's privacy was at stake, and also would their insurance rates go up? All these questions, and so you're being mindful about all of their health concerns. But what do you find the barriers are? For instance, are the insurance companies reluctant to join into an all-payer claims database? Right now, for instance, HMSA, who I work very closely with many times each day and week, they have 700,000 of the individuals in our state insured. They have the data already. They know more about the health of their patients, their consumers, than anybody else. Why would they want to share it? Are they reluctant, Beth, to share the data?
Well, actually, I think HMSA and the other insurers are good partners with healthcare transformation, and they are approaching this cautiously, as they should, but working with us because they see the potential value. So it may not directly help them with their patients immediately, but if we can put together more actionable data that will help us inform our healthcare transformation activities, then everybody wins. We have a healthier population, we control costs more effectively, they have more information that they can use as well.
Yeah, I think I see the point because, for instance, this year, and I have a great deal of respect for the guy who's helming their company, for Mike Gold, and he described to me that they, for instance, ran into a lot of loss this year because their Akamai Advantage program cost them, they lost $56 million this year, which in the state of Hawaii is a big chunk of money for a population. And the reason that they lost the money was because the physician community, the provider community, hadn't fully documented the extent and severity of the illness burden, especially chronic disease, that was in that population of older Hawaii residents. So because we hadn't coded it properly to say, like, for instance, to just write someone had diabetes, the federal government would give us a certain amount of money for the care of that individual. But if that individual actually had diabetes with retinopathy, with also neuropathy, with some early renal disease, a much more complex patient that needed a lot of care, the cost would be much higher. And in Hawaii, we hadn't gotten sophisticated enough with our documentation to put all that in there. So when the feds reimbursed HMSA to in turn reimburse the providers, they came up way short, and it sent a ripple effect through their whole organization. Rates are going up. What you're suggesting is if we do a good job as partners with the all-payer claims database, then we can actually say to HMSA, hey, look, this is an area that you need to focus on to get that care to people so that rates don't go up, or so that we can afford that new medication that's coming in for hepatitis, or so we can afford the universal care that we'd like for children that we've fought for over the years. Is this the focus of the project? How will it be done?
You said it perfectly, Doctor. It's important to note that our incentives are perfectly aligned with the insurance companies.
Interesting.
They want a healthy population. We want a healthy population. They're no fools. They're a multi-million-dollar company for a reason.
Right.
Other states have compelled their insurance companies to participate. Our plan is not to go down that road. Maybe that will change and we'll come knocking on your door, but I really don't think so. My communication with them thus far is they appreciate the value of this, and they know that it's the way of the future and that it's ultimately coming. And furthermore, they would like to look at this aggregated data. They want to take a look and slice it and dice it and come up with answers, because even though they've got a large market share, how much more valuable is the entire market data, and they've got the analytics and the ability and the resources to use that.
Right. We seem to be in a unique spot too. Beth alluded to it earlier on. The way we live in the state of Hawaii, we have about 350,000 individuals on Medicaid, about 175,000 or so workers or dependents on EUTF. So that combined number of well over 500,000 people in a pretty small state already captures a lot of people that have a state plan.
Yes.
Is that our first pool of people to go into the database?
We feel that that's probably the most accessible data, because as being related to the state, that we'll be able to pull that data in. But having said that, it still is going to be challenging to make sure that the data all matches up. And we also don't want to go on a fishing expedition and say, give us everything and we'll see what we want. We really want to target this to the data sets that are going to be most related to what we're trying to do with behavioral health and oral health and certain chronic diseases. And we're going to be working closely with our stakeholders to make sure that what we're identifying really does make sense.
Let me ask you a question about that, just to get your opinion. So some of the work that we've done has uncovered one of the kind of prevailing principles in healthcare, which is a very small number of people in general do tend to utilize a pretty large hunk of the healthcare spend and healthcare resource. In my organization, we got one snapshot, and it was 3.6% of our population was consuming 61% of all of the healthcare dollars. Is it better for you guys, as you build this program up, to focus on that 3 or 5% people and then figure out how to act? Or do you come at it from the other side, which is to look at all of the people to isolate who those 3% or 4% are to help? How do you approach it from a tech standpoint?
Well, that's a big challenge, and it's hard to really analyze the data before we have the data to analyze. It's a sort of a chicken and egg problem.
Okay.
Once we've got a meaningful data set to look at and form up actionable information, intuition tells me that you go to what they call the super utilizers, the ones that are utilizing a lot of services. But intuition is often proved wrong. So I think from attacking the data, we'll look at both in parallel. Could be, if we can save $1 on 1 million different files versus saving $1 million on one file, is it the same? Sure, right? The data will rule out.
Yeah, but I think also at the same time, you're looking at the bigger picture, which is the overall health of our entire state. And I know that that's been a passion of Beth's back to her primary care association days, and getting large numbers of people access to services that we don't often have. So I can see the value in having the full breadth of the data, so we know who needs dental care, who needs mental health care, and maybe as we go forward, how it's predictive that we can know where in the next generation we're going to need to invest in newly trained providers, which facility. Like we probably should have expanded our mental health care facility years ago, but we didn't know there was going to be a spike in methamphetamine use causing psychosis. Who could have predicted that? So maybe with some of these systems, we're going to enter into a new era. Let me ask you a question, just because I don't understand, just give me the technical nature a little bit. As you're sitting there developing the program, how does it work? Do you go to the insurers? Do you go to all of the people with data and start producing contracts? Or is it more of a tech process where you're doing software work?
The buzzword for that is called data governance,
okay.
And that is almost as challenging a problem as the technical piece because you're dealing with institutions, you're dealing with egos, you're dealing with turf and silos.
Yeah.
Everyone that's got the data up to this point has done a yeoman's job of protecting it. So there's a trust piece and a sort of almost a bandwagon approach. Once it becomes clear that you've got a stable platform and the security is there, the contracts, the human element follows.
Yes. Let me play devil's advocate. What if a guy like me, a legislator, said, who's also a dog, I guess, who says, the data is the patient's data. Beth goes in to see a doctor and her physician, he or she says, here's your, now you have a new piece of technology. We're going to put it right into there, or you have your data. Does it then become easier? Is it easier for you if I say all citizens own their own data, therefore nobody can be an impediment? Or does that make it just chaotic as can be?
Okay, so now I've got to put my lawyer hat back on. I really don't like the sound of that. I really believe in the doctor-patient privilege.
Yes.
Also the attorney-client privilege, but that's another issue. But I think it's sacrosanct. What the communication between the doctor and their patient must be kept privileged. And there's technology to do that. In the old days, you'd have your note card or your file. Well, that was pretty easy. You just wouldn't let it out. Now that we've got electronic health records, it's more of a challenge, but not an insurmountable challenge. So from a technical standpoint, what's done is you strip away all the personal information so that just the metrics go through.
Mm-hmm. Gotcha. And then as people then have access, that access becomes privileged but controlled. So the nephrologist who sees the patient after several weeks for the consultation has access just to what is necessary and approved, so they don't necessarily see a piece of social data that wasn't to be shared, or socioeconomic data, or what have you. Nor does the insurer. Historically, we've not really had that problem here in the state of Hawaii, but I do understand that it was a very big problem in many different venues about refusing insurance and cranking up the rates and so on. Now that seems to, from the Affordable Care Act, kind of changed. That's a big change. Is that going to be a challenge? I mean, how about these kind of filters? Is that hard for you to come up with?
I really wish I brought my whiteboard, because when you talk about this, it's helpful to sort of visualize the graphics to explain exactly what you said in a more visual way.
Yes.
But you're correct. The nephrologist doesn't necessarily need to know that you were just released from jail.
Right.
And the social worker may or may not need to know any particular piece of information. That's where the data governance piece is huge. Who gets to see what and where?
Yes.
If you're a researcher, if I come in from a pharmaceutical company and I want to look at a comparison of Pacific Islanders, Asians, Caucasians, all taking Plavix, say, as for a topical drug.
Right.
Well, they don't care what the name of the person is or their address or even what street they live in. None of that is relevant. But what is relevant to them is the ability to pull out meaningful information.
Right, and how many people had bleeds, and how many, therefore, neurosurgeons did we need in a certain region, or gastroenterologists to take care of people. So in that way, it sounds a little bit like what's the word in marketing? Was it micro targeting, something like
That's
to
right.
market? Yeah. So we might be able to get a better grasp. Like just a few years ago, Beth will be able to confirm we did this. We didn't even know where all of our providers were. We didn't know how many physicians. We knew we were short overall on the number of physicians, nurse practitioners, and PAs across the state, but we didn't know how short, and we didn't know in what areas. So we actually had to commission work through JAPSOM, our medical school, with Kelly Withy, who's done great work, to actually match that from a data standpoint. But we haven't taken it to the next level yet. Now, yes, we know where the doctors are, but we don't know if they're actually needed there. We know in general you need primary care providers everywhere. We know you need dental care and prevention everywhere. But do we really need a group of 4 gastroenterologists in one community or not? The only indicator we have is whether they can stay in business and whether they seem to meet the community needs. But that's somewhat subjective. But to objectively know, how many GI bleeds did we have? How many colon cancers could we address and prevent in a larger area will be so great once you have the data.
For sure. I mean, imagine, we were talking before about these hot maps. Imagine if I could put on your legislator hat, if I could go to the legislature and say, look, why don't you give a tax break to every a person that's going to treat diabetes in these hot zip codes?
Yes.
Right? Great policy,
right?
You can apply your policy levers of taxation or benefits or
Yes.
grants to put the Band-Aid on the wound, if you will,
Right.
as opposed to just slapping one on. If you don't put it on the right spot, it doesn't work quite as well.
Yeah, and we've been flying blind in the dark for many years, I think, with this, and I think that many of the solutions you're coming up are going to really help drive a better healthcare system. Amazingly, we've come near to the end of our program. Any final thoughts on what you'd like to see for the state of Hawaii with your work, with data work for healthcare?
Well, I just want to say that I've really felt a lot of aloha from everybody that we've reached out to, the insurance, various of the state agencies. People get it. People that have been working in this area get it. And I'm guardedly optimistic.
Good. Well, if they get it, we won't mind if they pay for it. So going forward, we're going to encourage them to be very supportive of these programs because I think they're going to help drive good health policy. So I just wanted to say thank you, Beth.
Thank you. Always a pleasure, Josh.
Great to see you. Thank you, Bryan, for joining us. And I hope that over these coming, maybe every 6 months or a year, we can update ourselves because I think this is a broad process to improve our healthcare system, and it seems like we're on the right track. So thanks for joining our state in this program.
Thanks for having us.
You bet. This was Josh Green, Healthcare in Hawaii. We'll see you again next week where we'll talk about kidney disease in our state. Take care.